Thanks everybody for joining us. Before we start with Dr. Lyle, let me introduce Dr. Melissa Lyle, and the bio is on the screen for those who can read it. I'll just highlight a few things. Dr. Melissa Lyle is a senior associate consultant in the Department of Cardiovascular Medicine at Mayo Clinic, Florida. She's an assistant professor in the Mayo Clinic School of Graduate Medical Education, with a focus on advanced heart failure and amyloidosis. And actually, she's the director of Cardiac Amyloidosis Clinic and the Cardiopulmonary Rehabilitation Program, which is a multidisciplinary clinic. An impressive thing she did, she's actually a recipient of many accolades, but I just mentioned to her, I was very impressed by the fact she is the founder and the president of the American Medical Women's Association. She started while in medical school, a second year medical student. She completed her medical residency and general cardiology fellowship at the Mayo Clinic in Rochester, Minnesota. And during her fellowship, she spent a year working in the amyloid clinic. After that, she completed another fellowship in heart failure and transplant at Emory University. She is well published, with her focus of research is cardiac amyloidosis, myocarditis, sarcoidosis, and heart failure with preserved ejection fraction, which will be the topic of her lecture today. I would like to take this opportunity again to thank Dr. Lyle for her dedication to teaching and research and for her time today. Dr. Lyle.
Perfect. Thank you so much. It's great to be here. And I will go ahead and share my screen so I can get my PowerPoint up. Okay. And hopefully everyone can see that, and we'll go ahead and get started. So for my learning objectives today, I really want to first discuss the prevalence of heart failure with preserved ejection fraction, and then also to identify the risk factors that are associated with HFpEF, and also to review the pathophysiology of HFpEF, including also focusing on the diagnostic approach, as well as reviewing treatment and management, our previous trials, and also emerging therapies. So let's start off with a case. We have a 66-year-old African-American female, past medical history of high blood pressure, which has been uncontrolled, type 2 diabetes, requiring insulin with an elevated A1C, and obesity with a BMI of 38. So her chief complaint when she presented to clinic was dyspnea on exertion, and her physical exam did show jugular venous distension and also lower extremity edema. So laboratory evaluation revealed a creatinine of 1.4 and an NT-proBNP of 400. We obtained a transthoracic echocardiogram that showed concentric left ventricular wall thickness, and then also an elevated relative wall thickness of 67, an elevated left ventricular mass index, as well as a preserved ejection fraction. So because of the increased wall thickness in an African American, although she did not have any significant red flag symptoms for amyloidosis, such as lumbar stenosis or carpal tunnel syndrome, we did want to make sure that we did rule out cardiac amyloid. So we obtained serum-free light chains, serum immunofixation, and a 24-hour immunofixation. And that did not reveal any evidence concerning for AL amyloid and no evidence of a monoclonal protein. So we thought we could confidently proceed with a nuclear PYP scan. So nuclear scintigraphy was normal, revealed a normal heart to contralateral ratio, and there was no uptake in the myocardium that was seen by our SPECT imaging. So the diagnosis was not consistent with TTR amyloid. She had also had a stress test recently that was equivocal, so we proceeded with a coronary angiogram that revealed normal coronary arteries. However, because we really did not find a clear etiology for her dyspnea, we decided to proceed with a right heart catheterization. So here are her hemodynamics. So as you can see from the left-hand corner, this is her right atrial pressure tracing. She had a right atrial pressure of around 6 millimeters of mercury. Her pulmonary artery pressure was 40/13 with a mean pulmonary pressure of 26. And her pulmonary arterial wedge pressure was 15 millimeters of mercury at rest. So as you can note, the hemodynamics were largely unrevealing at rest, but we decided to move forward with more provocative maneuvers, particularly since her symptoms were mostly dyspnea on exertion. So we went ahead with a passive leg raise. So with her feet up with a wedge pillow, we had a wedge pressure that increased to 18 millimeters of mercury. Then we went further to proceed with exercise in the cath lab, and that showed, and actually this was at the lowest level of exercise, just 20 watts, that showed that her wedge pressure increased to 25 millimeters of mercury. And then not pictured here, but her mean pulmonary artery pressure increased to 36 millimeters of mercury. So based on her exercise hemodynamics, we felt that her diagnosis was consistent with heart failure with preserved ejection fraction. And for treatment, we focused on optimization of her medical therapy, including adding additional antihypertensive agents, spironolactone, and then also we worked very hard on weight loss and exercise training. So what is heart failure with preserved ejection fraction? Well, HFpEF really focuses and hinges on the clinical signs and symptoms of heart failure in someone who has a preserved ejection fraction. So what exactly is defined as a preserved ejection fraction? Well, based on prior trials, it's been variably classified as an EF that ranges from anywhere from 40 to 55%. But our current guidelines do state that it's an EF that is greater than 50%. And also that's in the context of having abnormal left ventricular diastolic dysfunction. And that can be seen and evident on Doppler echocardiography or on cardiac catheterization. So as mentioned, our 2013 ACC, AHA, HFSA guidelines really define heart failure with preserved ejection fraction as an EF that's greater than or equal to 50%. However, the 2016 European Society of Cardiology heart failure guidelines define HFpEF by an EF that's greater than or equal to 50%, but also signs and symptoms of heart failure. In addition to elevated levels of natriuretic peptides, whether that's a BNP greater than 35 or an NT-proBNP greater than 125. And then at least one additional criterion being relevant structural heart disease, and that's left ventricular hypertrophy or left atrial enlargement, or evidence of diastolic dysfunction, again, by echocardiography or cardiac catheterization. A little bit about the prevalence and epidemiology. So 50% of all heart failure patients actually do have a preserved ejection fraction. And so we know that the HFpEF prevalence is increasing. And in fact, it's now the most common form of heart failure, affecting about 3 million adults in the US alone. And this is a graph here that's from the Get With the Guidelines Heart Failure Registry. And this was a hospital-based quality initiative that was launched by the American Heart Association. Looked at over 110,000 hospitalized patients with heart failure in the US. And as you can see here, the blue from the blue line, the trend for heart failure with preserved ejection fraction has been increasing, whereas the heart failure with reduced ejection fraction hospitalization is actually decreasing. And then that sort of mid-range ejection fraction has remained stagnant over time. And HFpEF outcomes, so a lot of the data remains the same, unfortunately, that it has been for quite some time. So our 5-year survival after a heart failure hospitalization continues to be only 30 to 35%, and that's regardless of ejection fraction. And here, this is a little bit of an older graph, but it is still very relevant. And as you can see, there's really been no trend toward improvement in survival for HFpEF patients. So I'd like to take a moment to talk about the pathophysiology of HFpEF. And there's both cardiac and vascular etiologies. In terms of cardiac etiologies, we're really talking about ventricular diastolic dysfunction, and that's with either at rest or that's induced by stress, whether that stress is exercise, tachycardia, or hypertension. And left ventricular hypertrophy, impaired relaxation, and myocardial stiffness all play into ventricular diastolic dysfunction. And also then we have cardiac hypertrophy and protein kinase signaling that we'll talk about in just a second that leads to cardiac etiologies as well. And then arterial stiffness is really the main vascular etiology that's associated with HFpEF physiology that we see. So talking a little bit more about the protein kinase signaling. So this diagram illustrates protein kinase A pathway in cardiac muscle. So as we all remember from medical school, the beta-1 receptor is going to activate adenylate cyclase, which then goes on to result in an increase in cyclic AMP. And so cyclic AMP is then going to activate your protein kinase A. And what protein kinase A does is it increases intracellular calcium and also calcium signaling. And it increases intracellular calcium by phosphorylating L-type calcium channels, but it also will phosphorylate phospholambin. Phospholambin, once phosphorylated, is actually going to release its inhibitory effect on the circuit ATPase, allowing for more calcium to be uptake, to have increased uptake of calcium into the sarcoplasmic reticulum. And then that just enhances calcium cycling in general. This next diagram focuses more on the protein kinase G signaling pathway. And this is thought to really counteract that previous protein kinase A pathway that we just discussed. So nitric oxide and also natriuretic peptides as well are going to stimulate guanylate cyclase, and then that increases the cyclic GMP. And cyclic GMP is then going to activate protein kinase G, which downstream leads to essentially vasodilation. And it's important to remember here that phosphodiesterases are actually going to hydrolyze cyclic GMP and cause the increased breakdown. So that's why previous trials had really evaluated the role of phosphodiesterase inhibition and nitric oxide administration in HFpEF, because they were aiming to try to augment this nitric oxide cyclic GMP PKG signaling pathway. So traditionally, the pathophysiology behind HFpEF was thought to be attributed mostly to hypertensive heart disease, and this would lead to concentric hypertrophy and fibrosis, eventually resulting in remodeling and diastolic dysfunction. However, there's been a lot of new evidence that shows now that systemic microvascular endothelial dysfunction and inflammation that's related to underlying comorbidities has been seen as an additional mechanism for the development of HFpEF. Those things are going to lead to not only muscle inflammation and microvascular endothelial dysfunction, but also leads to increases in oxidative stress, which then result in the decreases in that pathway we just discussed, that nitric oxide cyclic GMP PKG pathway. All of those things downstream lead to more cardiac remodeling and dysfunction. So now in 2020, though, we realize that HFpEF is driven in part by obesity and the metabolic syndrome, in addition to hypertension, a sedentary lifestyle, and also aging. So we realize that this is a systemic process. It doesn't only affect the heart, but it affects the lungs, the liver, the kidney, skeletal muscle, and then also the visceral adiposity. And so with that increase in visceral adiposity, it not only increases inflammation and insulin resistance, but it also results in increased BMP clearance. And we'll talk a little bit further about that. But all of these comorbidities lead to additional stress and changes in the periphery that then subsequently lead to increased inflammation and secondary myocardial injury. So as we can see here, we've discussed that the metabolic syndrome, the obesity, type 2 diabetes, and hypertension all can lead to chronic systemic inflammation and an increase in the inflammatory markers, our CRP and IL-1. And then that leads to myocardial remodeling and also dysfunction. And this is all through a signaling cascade that begins with coronary microvascular endothelial dysfunction. And there can also be reactive interstitial fibrosis with hypertrophy and also cardiomyocyte stiffness. All of these things can be seen. So we've discussed the cellular basis for heart failure with preserved ejection fraction, but what about the hemodynamics that we're seeing? So as we all know, it can result in prolonged relaxation, and that creates a problem with diastole. And that eventually will lead to elevated filling pressures. But we also look at ventricular stiffness or diastolic compliance. And so this graph here on the right looks at the diastolic pressure volume relationship with pressure on the y-axis and LV volume on the x-axis. And in HFpEF, the diastolic pressure volume relationship is actually shifted upward and to the left. And that indicates a much stiffer ventricle. So we've already touched upon some of the risk factors, and we all know the common risk factors that are associated with heart failure with preserved ejection fraction. And really, this is a reminder too that it's a heterogeneous syndrome of phenotypes. So one phenotype may be related to all of these comorbid conditions. So age, hypertension, obesity, diabetes, atrial fibrillation, all factors that can contribute to HFpEF. But an interesting point to make is gender. So about 60% of HFpEF patients are female. And these are typically females that are in the postmenopausal setting. And it's thought that the loss of estrogen actually will lead to reduced nitric oxide bioavailability, and then that leads to a decrease in that signaling pathway, the nitric oxide, CGMP, PKG pathway. And then that leads to a cascade of events on the heart. And so in general, the thought in the past has been that the female sex likely protects from heart failure with reduced ejection fraction. And so women are more likely to get heart failure with preserved ejection fraction as they age. But another big risk factor to really highlight is physical inactivity. So this diagram is from a recent JACC article in 2017, and this illustrated a significant dose-dependent association between higher levels of physical activity and the risk of heart failure with preserved ejection fraction. So the higher the degree of physical activity, the lower the risk of HFpEF. This is another interesting article from JACC that focused on the interplay between HFpEF and diabetes, looking at the burden of comorbid heart failure with preserved ejection fraction and diabetes. So we know that diabetes can be associated with increased systolic blood pressure and congestion and volume overload. So then in terms of treatment options, theoretically, sodium glucose cotransporter 2 inhibitors, the SGLT2 inhibitors that have gotten a lot of acknowledgement recently, might help with the increased volume, and that's by restoring sodium delivery to the distal tubules, promoting natriuresis and diuresis. So it's an interesting comorbid condition that's associated with HFpEF, and by treating this more more as a disease of phenotypes and focusing on specific phenotypes, we can gear our management towards diabetes in that certain subset of patients. So the diagnostic approach of HFpEF really depends largely on the pretest probability. So is the patient someone that we think likely has HFpEF? Is this patient someone who has typical comorbidities, atrial fibrillation, diabetes, hypertension? Are they an older patient? And then we like to think about the physical exam. Does this patient have physical features and clinical signs and symptoms of heart failure? So are they complaining of excess volume? Are they complaining of orthopnea and P&D? Or are they even potentially more advanced, complaining of more abdominal fullness, anorexia, and early satiety, indicative of more advanced heart failure and right-sided heart failure? So our physical exam would often show an elevated BMI in our obese patients and hypertension. And then the assessment of congestion is going to include close evaluation of looking for jugular venous distension and S3 gallop and lower extremity edema. And then, of course, on chest radiography, we can see cardiomegaly sometimes, interstitial edema, and then pleural effusions. So electrocardiography is another tool that we use. It can often show left ventricular hypertrophy, left atrial enlargement, and atrial fibrillation. And our laboratory evaluation may show an elevated BNP or NT-proBNP, but it's important to remember that natriuretic peptides may be normal in up to 30% of HFpEF patients. And this really brings up the question of this BNP deficiency that we often see in our obese population. So we know that natriuretic peptides are lower in HFpEF patients compared with heart failure with reduced ejection fraction. And why is that? Well, HFpEF patients do have lower wall stress. We have to think back to Laplace's law, and that wall stress is proportional to our radius divided by thickness. And these patients have a small cavity size and increased wall thickness often. And so therefore they do have lower wall stress, so less wall stress and wall stretch, less release of BNP. But also obesity is associated with reduced natriuretic peptide levels. And so we see increased clearance via the natriuretic peptide receptors and adipocytes. So that's an important contributor. Obesity, lack of wall stress, and insulin resistance can all lead to chronic BNP deficiency. And this is further going to propagate the hypertension, fluid retention, and increased adiposity that we see in our patients. So it really is sort of a vicious cycle. So going back to our diagnostic approach, echocardiography is another key component of the diagnostic algorithm. And so echocardiography for 2D, we're going to look for left ventricular remodeling or hypertrophy. And then we often see that elevated relative wall thickness. We can see an increased LV mass index. Our cutoffs would be 95 in women and 115 in men. An increased left atrial volume, and then reduced global longitudinal strain. We also use Doppler echocardiography to aid in our assessment of left ventricular filling pressures. So we're looking for impaired left ventricular early diastolic tissue velocity, so an E prime septal of less than 7, and that's really going to be indicative of impaired relaxation. And then an elevation in the E to E prime ratio, particularly greater than or equal to 15, a decreased, a steep deceleration time, a slope that's going to give you a decreased time of less than 140 milliseconds, and then elevated right ventricular systolic pressures, which are going to correlate with our pulmonary artery systolic pressures. With that elevation, it's often secondary to chronic left atrial hypertension. So although echocardiography is a very helpful tool for us, it's important to remember that the gold standard for diagnosis of heart failure with preserved ejection fraction still remains the right heart catheterization. But it's also to remember several caveats for the right heart catheterization. And the first is that if the filling pressures are normal at rest, we need to be exercising the patient. A lot of times our patients are coming in and their main complaint is dyspnea on exertion. So they're not having symptoms at rest. We take them to the cath lab and their hemodynamics are normal at rest. So we need to do some sort of provocative maneuver to try to stress them to see what are their filling pressures doing with that additional stress or exercise. Also remember to always review the hemodynamic tracings yourself. So there's significant respiratory variation in the wedge pressure that can be seen with patients with lung disease or obesity, and these are often comorbidities that we see in this HFpEF population. So you can be swayed by a relatively normal wedge pressure, but then when you look at the tracings yourself, you actually realize that the end diastolic pressures that you're seeing at end expiration are actually elevated. So always look at them yourself and measure at end expiration, particularly in those patients with significant respiratory variation. And also remember too, a couple of things for the tracings. You may see a big V wave even in someone who doesn't have significant mitral regurgitation. So if you look at this tracing here, this was a tracing that was taken from a left ventricular tracing and then a left atrial pressure tracing. So this was a true left atrial pressure actually obtained via transeptal puncture. And you see this very large V wave, over 50 millimeters of mercury. And there was actually no evidence of significant MR. This was all just poor left atrial compliance and a very stiff left atrium. So a couple of things in terms of the exercise. So once you have normal hemodynamics at rest and you want to exercise the patient, then you can move forward with a low workload of 20 watts with an exercise, a supine bike in the cath lab, and increase every 2 to 3 minutes by 10 to 20 watts to exhaustion. And if your lab doesn't have the capability to do exercise hemodynamics, the next best step is a volume challenge. So with a volume challenge, you just need to make sure that your right atrial pressure is less than 10 to 12 millimeters of mercury. And then you're infusing about 500 cc's of normal saline over about 5 minutes. And you're looking for an increase in the wedge pressure, but also remember that the cardiac output should increase with that volume challenge. If it doesn't increase, then that could be indicative of HFpEF as well. And as a reminder, the true definition would be HFpEF defined invasively by a wedge pressure greater than or equal to 15 millimeters of mercury at rest and greater than or equal to 25 millimeters of mercury during exercise or other provocative maneuver. So this is a study from Barry Borlaug in 2017, and it really illustrates the utility of testing, exercise testing in HFpEF. Therefore, right heart catheterization with exercise is truly the best option and the gold standard for diagnosing HFpEF, and that was shown from our case earlier as well. So this is another excellent recent study that was published in JACC Heart Failure by Kavita Sharma at Johns Hopkins, and she was looking at endomyocardial biopsy characterization in HFpEF, because it's important to remember that HFpEF is a diagnosis of exclusion. We want to exclude all other possibilities, our infiltrative cardiomyopathies, valvular or ischemic etiologies. So in this study, they looked at 108 patients with an ejection fraction greater than 50%, patients who had presumed HFpEF, and those patients underwent a right heart catheterization and an endomyocardial biopsy. And most of the biopsies illustrated fibrosis or hypertrophy. But it's important to remember that actually about 14% of them had amyloid deposits. And so it's an important reminder to make sure that we're ruling out those infiltrative processes like cardiac amyloid before committing to a diagnosis of heart failure with preserved ejection fraction. So this is a nice slide to really talk about all of the mimickers that we could see briefly. So the first being cardiac amyloid. So if we're seeing someone who has thick walls, doesn't have a significant history of hypertension, and maybe is even struggling with hypotension, those are people that we definitely want to rule out cardiac amyloid. So obtaining the serum-free light chains, serum immunofixation, 24-hour immunofixation to rule out AL amyloid or a monoclonal protein. And then if those are all negative, then moving forward with nuclear scintigraphy or a nuclear PYP scan to help diagnose TTR amyloid. And if you do get a diagnosis of TTR, making sure to always get genetic testing so that we could determine if it's wild type or hereditary, which then could help in determining which agent, which TTR specific therapy we would choose. For most of our patients, for cardiomyopathy alone, whether it's wild type or hereditary, we would be choosing one of the TTR stabilizers. So tafamidis or diflunisal if they don't have any renal contraindication or symptoms of heart failure. And then from another hereditary standpoint, if they do have polyneuropathy, thinking about the RNA, the TTR RNA silencers, whether it's patisiran or inotersen. We also want to make sure that we don't miss hypertrophic cardiomyopathy. So with hypertrophic cardiomyopathy, using echo and cardiac MRI to look for thick walls, delayed gadolinium enhancement, but also making sure that there's no component of left ventricular outflow tract obstruction, because that would alter how we treat these patients. So if they have a significant obstructive component, then we would want to be using beta blockers and calcium channel blockers to decrease contractility, and then also avoiding excessive afterload reduction. And then those are the patients that if we can't treat them medically, we would be thinking more about septal reduction therapies, either from an alcohol septal ablation standpoint or a septal myectomy. Cardiac sarcoid can also be a mimicker of HFpEF as well. So with cardiac sarcoid, you can see thick walls. You can also have a dilated cardiomyopathy as well, but you can see increased left ventricular hypertrophy. We typically are going to diagnose this with cardiac MRI or more frequently FDG PET. And this is important not to miss this diagnosis because we really need to use immunosuppressive agents to treat initially. Constrictive pericarditis, that can actually present as right heart failure and often gets diagnosed as just heart failure with preserved ejection fraction. We use echocardiography and also invasive hemodynamics to establish if there is a component of ventricular interdependence and true constriction. And in that case, in the more extreme scenario, we would be thinking about pericardiectomy. And then, of course, kind of the more classic things like valvular heart disease, making sure that we can improve a patient's symptoms with just surgical or percutaneous valve repair replacement. And then coronary artery disease, making sure that someone isn't having ongoing ischemia that we could potentially treat with revascularization, and also optimizing their guideline-directed medical therapy. Rarely, sometimes people can have a high output heart failure that mimics HFpEF, and these are our patients with typically with end-stage renal disease on dialysis that have a fistula. Also, myocarditis can be a mimicker. It is important to make this diagnosis, particularly for prognosis, but also occasionally for treatment. We would use immunosuppressive agents for giant cell or eosinophilic myocarditis, but these typically would present as a more fulminant myocarditis. So I just wanted to touch on all of these things to highlight that the reason why it's so important, all of these can present as heart failure with preserved ejection fraction, but as we'll talk a little bit more about, we don't have a clear treatment option for HFpEF. But in these things, our treatment would be separate. And so we need to make sure that we're not missing any of these diagnoses so that we could actually have therapy to offer the patient. And I just want to take a brief moment to talk about restriction and constriction, because these are entities that do frequently mimic HFpEF. And so with restriction, it often can be seen in infiltrative cardiomyopathy. So these are typically our amyloid patients. These patients are going to have a speckled appearance of their myocardium frequently, They have the severely decreased tissue Doppler E prime velocity, and then they often have a reduced global longitudinal strain. And then as you can see here, this is a very common pattern that we would see, this apical sparing pattern or a cherry on top. And then the constrictive physiology, that you would see typically a septal bounce. You may see respiratory variation on the mitral inflow on Doppler echocardiography. And then you also may see annulus paradoxus, and that's basically where you have a preserved E prime, and despite other evidence of grade 3 diastolic dysfunction, your E prime is relatively normal. And then annulus reversus is when your septal E prime is actually greater than your lateral E prime. And this is really due to exaggerated septal motion and the setting of ventricular interdependence and also pericardial constraint. But it's important to not only recognize if this is someone with restriction or constriction, because we'll treat it differently than just run-of-the-mill HFpEF, but then also to differentiate between the two because we treat them dramatically differently. So risk scores, though, can also be very helpful in determining the likelihood that someone has HFpEF. So this is the HFpEF score that was published by Yogesh Reddy and Barry Borlaug in 2018, and it's very helpful to determine the likelihood that a patient who comes in with dyspnea on exertion and also has a preserved EF, that likelihood that they have heart failure with preserved ejection fraction. So this score is going to give you a set of points for each comorbidity. So if someone's overweight, they get 2 points. If someone is hypertensive, they get another point. Atrial fibrillation will get you 3 points. And then pulmonary hypertension, being older, age greater than 60, or having elevated filling pressures will also give you additional points. And so then the nomogram is going to assign you a probability of HFpEF based on the total number of points, with a score of 7 or higher, leading to a much higher probability of HFpEF. The European Society of Cardiology also has a HFpEF diagnostic scoring tool. It's a little bit more cumbersome than the other HFpEF score, but it incorporates function, morphology, and biomarker characteristics to help determine the likelihood that someone has HFpEF. And this is a nice summary slide that compares the HFpEF score with the ESC scoring system. So as you can see here, lower scores 0 to 1 are going to be low likelihood that this patient has heart failure with preserved ejection fraction. Whereas there's the higher scores, a score of 6 to 9 for the HFpEF score or the ESC score of 5 to 6, are going to give you a much higher probability of someone having HFpEF. And then it's important to remember this intermediate probability. And so when it's unclear if the patient has HFpEF or not, then the recommendation would still be to proceed with some sort of hemodynamic exercise test. So finally, we move on to therapy. So unfortunately, there is no clear therapy or treatment option for HFpEF at this time, but it's important for us to think about how we're going to define each patient. And we need to think about the HFpEF phenotype. For example, is this patient someone who's had long-standing coronary artery disease and frequent episodes of ischemia? And is it someone that we need to revascularize? Or is this someone who has long-standing issues with obesity and physical activity that we need to focus more on an exercise regimen and weight loss? And that really can guide our therapy management, because taking the same therapeutic approach for each patient is not going to work. However, treating all comorbidities, carte blanche, is still very important. And then focusing on decongestion and using diuretic therapy to help with people that are presenting with signs and symptoms of hypervolemia. Heart failure education is also going to be very important. And that is just as important as it is in heart failure with reduced ejection fraction. We also need it in HFpEF. Talking about sodium restriction and also diet and exercise. Finally, exercise training, though, is very important as well. Currently, CMS does not cover cardiopulmonary rehab for HFpEF, but multiple organizations are trying to work on getting that coverage. And so hopefully we'll have coverage for our HFpEF patients soon, because we do know that exercise training is beneficial for them. So here's the treatment algorithm that was proposed by Dr. Redfield in her New England Journal of Medicine article on HFpEF that was presented in 2016. And so, as mentioned, the current management of heart failure with preserved ejection fraction is primarily directed towards control of hypervolemia with diuretics, but also the use of mineralocorticoid receptor antagonists in selected patients. And then again, of course, that exercise training in addition to management of all of their comorbidities. So this table really highlights the multiple clinical trials of pharmacologic therapies of HFpEF that were unsuccessful. So really with no identified effective therapy. And I show this to you not for you to try to learn all of these trials, but to highlight that the lack of effective therapy is really not for lack of trying. So I do want to highlight a couple of specific therapies that are reflected in the guidelines. So the CHARM Preserved study from 2003, which included patients with preserved ejection fraction, and that was defined as an ejection fraction greater than 40%, included patients randomized to either candesartan or to placebo. And so candesartan did reduce the rate of heart failure hospitalizations, but had no effect, unfortunately, on CV mortality. And the iPreserve trial was a similar study that was done in 2008. And this is patients that were randomized to the angiotensin receptor blocker irbesartan, and similar results were found. No mortality improvement, but improvement in heart failure hospitalizations. So other studies actually focused on the nitric oxide cyclic GMP PKG signaling pathway that we discussed earlier in the talk. So the RELAX trial that was from 2013, this trial randomized 216 patients with symptomatic HFpEF. And in this study, it was defined as an ejection fraction greater than 50% with New York Heart Association class 2 to 4 symptoms. And they were randomized to either the phosphodiesterase 5 inhibitor sildenafil versus placebo. The primary outcome of this study was a change in exercise capacity using peak VO2 as part of our cardiopulmonary exercise test. And unfortunately, sildenafil did not improve exercise capacity or clinical status. The next trial was the Indy HFpEF trial from 2018, and this study randomized 105 patients with HFpEF to inhaled nebulized inorganic nitrite, and that was for 4 weeks versus placebo. But again, unfortunately, inorganic nitrite was not effective at improving exercise capacity in patients with HFpEF. So the NEAT HFpEF trial was from 2015, and this randomized 110 patients with chronic HFpEF to a long-acting nitrate versus placebo. So the long-acting nitrate, isosorbide mononitrate, appeared actually to hinder rather than improve activity level. So that's reflected in the guidelines as not at all a recommendation at class 3 harm. So we all know about the Topcat trial. So what exactly did that look at? So this is a very important trial from 2014. They had 3,445 patients, and they had to have symptomatic HFpEF. And in this trial, it was defined as an ejection fraction greater than or equal to 45%. They were randomized to either spironolactone or placebo. And then the primary outcome, the composite primary outcome, was cardiovascular death, aborted cardiac arrest, or heart failure hospitalization. Well, unfortunately, spironolactone did not reduce the rate of the primary outcome, so it was a negative study. But it is important to note that heart failure hospitalizations did occur less in the spironolactone group compared with placebo. so 12% compared to 14.2%. And then the post hoc analysis of Topcat is actually pretty interesting. So approximately half of the Topcat cohort was enrolled in North America and South America, and the other half was enrolled in the Republic of Georgia and Russia. So a post hoc analysis looked at geographical differences, and these differences actually confounded the results and interpretation of the Topcat data. So patients that were in the country of Georgia and Russia had fourfold lower events than their American counterparts, and they were less likely to display typical effects of spironolactone. And in fact, a sub-study measuring plasma levels of an active metabolite of spironolactone at the 12-month visit reported that the metabolite was undetectable in a higher percentage of Russian patients compared with the US. So all of these analyses suggest that maybe the patients enrolled in Russia and Georgia didn't have a typical true HFpEF syndrome and possibly weren't as compliant with taking the drug. And so when we restricted the analysis just to the Americas, the risks of the primary outcomes, remember that cardiovascular death, aborted cardiac arrest, and heart failure hospitalizations actually were reduced significantly with spironolactone compared to placebo. So that is an important caveat of this study. So other therapies. Well, we have all heard a ton about the Paradigm trial. And as a reminder, the Paradigm trial showed significant benefit with sacubitril valsartan or an ARNI and Entresto and heart failure with reduced ejection fraction in regard to reduction in cardiovascular death and also heart failure hospitalizations. The 2019 Paragon study was very important because it evaluated this role of that combination therapy with sacubitril valsartan, the angiotensin receptor blocker and neprilysin inhibitor, or the ARNI, its role in heart failure with preserved ejection fraction. So in this large study, they had 4,822 patients with symptomatic HFpEF, and this included an ejection fraction that was greater than or equal to 45%. Structural heart disease that was defined as left ventricular hypertrophy or left atrial enlargement, and elevated natriuretic peptides. And then they were randomized to sacubitril valsartan, the ARNI, or valsartan alone. And so the primary composite outcome for this study, again, was a composite of heart failure hospitalizations and death from cardiovascular causes. So at 35 months, the ARNI treatment, unfortunately, did not significantly reduce the frequency of the primary composite endpoint. So again, it was a negative trial. But it is important to remember that a small borderline significant reduction was seen with ARNI treatment in terms of the rates of heart failure hospitalizations, but all-cause mortality was similar and essentially the same between the two groups. But also there was a pre-specified subgroup analysis, and this basically suggested that there might be a benefit for sacubitril valsartan in patients with a lower ejection fraction who are still preserved EF, so an EF less than or equal to 57%, and also in women. So kind of an interesting point, but still wasn't powered to look at this specifically, so we don't know the true outcomes in regards to these groups. Well, what about invasive monitoring? So the CardioMEMS heart failure system is a FDA-approved pulmonary artery pressure monitor. And it was the CHAMPION trial that initially studied this, and they included heart failure patients that were randomized to the pulmonary artery pressure monitor guided therapy or just to standard therapy by physical exam. And so patients with pressure-informed therapy actually had a 39% reduction in heart failure hospitalizations. And this was observed when the analysis was restricted to HFpEF patients only. So overall, the pulmonary artery pressure monitor systems have been proven to reduce heart failure hospitalizations and also improve quality of life in patients with New York Heart Association Class 3 symptoms. So we should all be thinking about cardiomems in those patients with recurrent hospitalizations for heart failure and volume overload, particularly in those patients that have a difficult physical exam that you can't quite assess their JVP, maybe because of obesity or their body habitus. All things that we should think about. Maybe this patient would be a good candidate for a cardiomems. So other emerging therapies. So we already talked about the results of Paragon, but Paraglide is a new study that's going to be looking at the angiotensin receptor blocker, neprilysin inhibitor, looking at the effects of sacubitril valsartan compared with valsartan, and looking at specifically the changes in NT-proBNP and outcomes, safety, and tolerability in patients with HFpEF. And in this study, it's defined as an EF that's greater than 40%, who have been stabilized during the hospitalization for acute decompensated heart failure. And it has to be initiated either in the hospitalization or within 30 days of discharge. So this is sort of similar to the Pioneer study that's going on for sacubitril valsartan in patients with HFrEF. Also the SGLT2 inhibitors. So this could potentially have a new role for HFpEF treatment, but we just have ongoing studies that need to be evaluated. So the inhibitors of the sodium glucose cotransporter 2 protein have been shown in the past to reduce the rate of hospitalizations for heart failure by about 31% in patients with diabetes. And the DAPA heart failure trial showed that treatment with dapagliflozin was shown to reduce the primary outcome of heart failure hospitalizations or cardiovascular deaths in patients with heart failure with reduced ejection fraction by about 26% compared with placebo in patients with or without diabetes. And so there are ongoing trials that are assessing the benefit of SGLT2 inhibitors in HFpEF. So this could be a really exciting therapy potentially for these patients in the future. So intraatrial septostomy devices. So this has sort of been another hot topic for HFpEF. And basically, HFpEF is caused by increased left atrial pressure. That is part of the pathophysiology. So if we were able to shunt the pressure to the right, could that help the patient's symptoms? So this may have a role in patients with significant left-sided heart failure symptoms. Your patients that are really struggling, particularly with orthopnea or PND. But then we still don't really know the sequelae of creating a shunt. And we should probably avoid this in patients who have significant right-sided heart failure symptoms because we're just going to increase that right-sided volume overload and pressure. So trials have used a percutaneously implanted intraatrial septostomy device. They've been shown to improve symptoms, functional capacity, and also exercise hemodynamics in patients with HFpEF. And so this device creates a very small left to right shunt, and if the shunt fraction is only about 25%, and that results though in a reduction in left atrial pressure. And so the shunt also increases pulmonary blood flow. So there's been a theory that's been propagated that maybe that enhances pulmonary vascular recruitment and distension, and that it increases the oxygen content of venous blood to reduce pulmonary hypoxic vasoconstriction, but that's sort of a theoretical assumption. But the Relieve heart failure and the reduced left atrial pressure trials are two ongoing trials that are evaluating these transcatheter intraatrial shunt devices. So potentially, I think in the right patient, this could be interesting, but we still have to wait on the results of these trials, and it's not included in our guidelines or FDA approved currently. So the failure of all of these clinical trials really to identify an effective treatment for HFpEF has been attributed to the heterogeneity of the clinical syndrome in the past. So we know that some patients respond well to some therapies and others respond well to other therapies. So classifying patients with HFpEF into subgroups of pathophysiologically homogeneous phenotypes might allow for better targeted therapies. And there appears to be a clear role for phenotyping HFpEF patients in the future to be able to better treat them. So these patients, we need to think about what is their true HFpEF phenotype, and then that helps us to determine how we're going to manage these patients. So finally, we're going to come to sort of the 2013 ACC AHA heart failure guidelines with the 2017 update. And it's very important to treat hypertension with a target systolic blood pressure of less than 130/80. And also have to remember that in HFpEF patients, they do often show an exaggerated hypotensive response to vasodilators. So it's important to consider the HFpEF clinical phenotype and if there is roles for other therapy. So thinking about if someone has coronary artery disease, do they have ongoing ischemia, and would coronary revascularization be appropriate? Do they have atrial fibrillation? We know that atrial fibrillation treatment remains the same as in non-heart failure patients, but prospective trials testing the efficacy of ablation, specifically in HFpEF, are needed. It's sort of an interesting concept because there is that association with ablation and left atrial dysfunction. Are we going to potentially worsen the left atrial dysfunction and left atrial pressure in our HFpEF patients? And then finally, kind of based on some of the trials that we discussed, you see this 2B, so a week recommendation for consideration of your spironolactone or your mineralocorticoid receptor antagonist or your angiotensin receptor blockers. And just as a practical reminder for initiating spironolactone, you need to make sure, particularly in the HFpEF patient, this is going to be a patient with an ejection fraction that's greater than 45%. And then this is going to be someone who has a GFR that's greater than 30. And then I like to remember the cutoffs of 2.5 for men for a creatinine and 2 for women. And then also a potassium needs to be less than 5. So the guidelines, by guidelines based on the RAILS trial, there's a strict recommendation for getting lab work in 3 days and then 10 days, and then getting repeat lab work monthly for the next 3 months. That's often very difficult for our patients, so I try to make sure that I have them come back for lab work in that 7 to 10 day range. And then just as a reminder, this class 3 recommendation is going to be that organic nitrates, inorganic nitrites, and then the phosphodiesterase inhibitors all have not been shown to be beneficial in HFpEF patients in clinical trials. So they are contraindicated in this patient population. And then finally, this is a really nice summary slide from Dr. Redfield's New England Journal of Medicine article, and it kind of touches on the objectives that I wanted to discuss. Basically, just remembering that in someone who comes in with signs and symptoms of heart failure, but they have a preserved ejection fraction, we want to think about exclude other potential mimickers, but we want to think about HFpEF as a diagnosis. And you can use electrocardiography, chest x-ray, lab work, and also echocardiography to help you make that diagnosis. But don't be fooled that if the natriuretic peptide levels are not as high as you would expect with someone who's presenting with signs and symptoms of congestion, they still might have HFpEF. They just might have that BNP deficiency and just have lower BNP levels. If you still are having trouble making a diagnosis, always proceed with a right heart catheterization to help determine their filling pressures. If all of their hemodynamics are completely normal at rest, but they're presenting symptoms, dyspnea on exertion, try to stress them a little bit. Passive leg raise, volume challenge, or the exercise hemodynamics as kind of the gold standard. And as we know, medications that help with our heart failure with reduced ejection fraction patients are not going to help with our HFpEF patients, but we can focus on decongestion, and then also focus on their specific phenotype, really choosing the phenotype and then catering your therapy to exactly what their comorbidities are. And then, of course, focusing on education and then increasing their exercise regimen. So with that, I will end and I'll take any questions.
Thank you very much. That's very well done. If anybody has any question, you can unmute yourself or you can type it in the chat section. Unfortunately, the time is not much left, but we'll do our best. We'll try to get the email for Dr. Lyle. Possibly we can email you with any questions if the time does not allow to answer those questions, because we have a lot of questions. Okay, anyone?
Yeah, Dr. Lyle.
Yes.
This is Brent Fideau in Pensacola. Great talk.
Oh, thank you.
My question is, so we're all getting up to gear for clinical oncology, and if you read a lot of the clinical oncology literature, you'll see that people that had childhood tumors or chemotherapy, we see people all the time in the echo lab that have abnormal strain. They may have a strain of 11, and are you there?
Yep.
Okay, and apparently a lot of these patients, they look like they have preserved LV function. There's going to be a subset of these patients that go on to be your heart failure with preserved EF, people that have had radiation. On a side note, in obstetrics, they're finding in their literature that women that had preeclampsia or had pregnancy-related problems such as that also have, could have abnormal myocardial substrate. And my question to you is, these are all stage A. Is there ongoing research or data you know about that empirically placing these patients on ACE inhibitors, aldactone, RAS inhibitors, any drug therapy to prevent the eventual development of heart failure preserved EF, or to monitor them? What is your thoughts on that group?
Yeah, so that's an excellent question, and you bring up a couple of really good points. I think the first to kind of mention in terms of women, absolutely, that's something that we really question and try to counsel for patients in our women's heart clinic, making sure that they're aware if they've had preeclampsia, they had gestational diabetes, all of those things are going to be putting them at risk. So 100%, I think the first step is to identify that those patients are going to be stage A, and also with our patients who've had prior chemotherapy. One caveat too, before I kind of answer your question, is particularly with our patients that have had radiation before, that we're just making sure that they don't have any evidence of constriction and that they're not having constrictive physiology from their prior, if they had chest radiation. So making sure that we don't miss that diagnosis. But in terms of otherwise, when they're stage A and at risk, unfortunately, we don't have any current available literature that would indicate that placing them on an ACE inhibitor, a beta blocker, or an ARB at the stage A standpoint is going to prevent them from developing further complications of heart failure in the future. Of course, once they get to the stage B and HFrEF, they would be a candidate. The caveat that I have is that I, in my clinical practice, am very quick to, if someone who has a preserved ejection fraction and they're coming in with any sort of signs that they might be volume overloaded, then I'm very quick to put them on spironolactone. But unfortunately, we don't have the evidence yet to show that we could do something prophylactically to prevent that. Hopefully, we'll have more information in the future, but right now, there's nothing that we have. But that's a great question.
Excellent. I have one more follow-up. I'm sorry.
Sure. No.
What about, you may have talked about this, I missed a little part, but I'm going to listen to your lecture again tonight. What about the transthyretin amyloid? We know that there's going to be a subset of patients that have this. Are you guys just doing your usual, the algorithm for amyloid? In other words, they have to have carpal tunnel syndrome, all the different spinal stenosis, neuropathy, or do you put your heart failure preserved? What subset do you put them through a pyrophosphate scan?
Yep. So that is a really good question. And we, whenever I see someone who gets referred to me for either HFpEF and I'm concerned about possible amyloid, typically I'm looking very closely at their echo, because often sometimes it gets missed, and it happens frequently in our echo lab where they get read out as normal wall thickness, but they might have an interventricular septum that's 13, but their relative wall thickness, their LV mass, the echo mass still works. But if you're seeing an interventricular wall thickness that's 13, or a posterior wall thickness that's 13, and someone who hasn't had long-standing hypertension, that's what triggers me to go ahead and think about amyloid. Now, I always do the screening questions. I always ask them for bilateral carpal tunnel, lumbar stenosis, biceps tendon rupture. There's also been a lower association, but it is still there with inflammatory arthropathy and polyneuropathy as well. If they have polyneuropathy and they don't have a history of diabetes or other reason to have significant neuropathy. So I still add those screening questions, but I have a very low threshold that if someone's coming in, they have really significant heart failure, you can use your echo to give you the strain pattern to help you have that classic pattern. But if I'm seeing increased wall thickness with no other reason that they haven't been an uncontrolled hypertensive patient, then I'm going to go ahead and screen them for amyloid. Because we know it's been an underdiagnosed disease in the past, and now we have such effective therapy that I think it's better to screen someone and just have it be negative than to miss it entirely.
Very good. Thank you.
Of course, of course.
Thank you. It's up to you, Dr. Lyle, to continue with any more questions.
Oh, I'm happy to answer any other questions, but I know that that's taking up y'all's time. So if whatever works for you, I'm happy to. I think I had my email on the first slide, but if either you or Patrick could email it out, I'm also always happy to answer any questions.
Wonderful. The email is in the chat section for everybody if you have any questions. I have one quick practical question, Dr. Lyle. You know, as you mentioned, those patients are very sensitive to volume overload, and they don't usually present with significant edema to the point you need to challenge them to diagnose that. So when you start them on diuretic therapy, how far do you push, and do you rely on symptoms when you push as long as the kidney function is stable? And do you add the diuretic therapy along with aldactone, assuming that aldactone is a potassium sparing, even if it's not effective?
Yeah, exactly right. So that's, I typically will go by symptoms. So like, it's very difficult in some of these patients with their JVP, with body habitus. So typically I go by symptoms. And I am very quick to add on spironolactone. One thing that I don't ever want to do is particularly if someone with normal renal function, if I'm adding on Lasix or torsemide and I'm having to give them potassium supplementation, then I chuck the potassium supplementation and add spironolactone. So I'm very quick to add on spironolactone for them. And then typically I'm going mostly by symptoms. That's where ideally, especially if you're having a lot of difficulty, the CardioMEMS is very effective because it can give us a clear answer and prevent patients from having to be hospitalized. So that's been a very effective tool, particularly, I think, for this patient population, because they are often obese and the physical exam I find often very difficult.
Thank you so much. I don't think we're going to take any more of your time.
Okay.
We appreciate that, and we'll be emailing you with any questions. And the email is in the chat section, as I mentioned, for everyone to communicate with Dr. Lyle. Dr. Lyle, thank you so very much and have a wonderful day.
Yes, thank you so much.
Pleasure.